Today I'm going to be dictating a pulmonary critical care history and physical consult. EF is an 87-year-old male patient. Date of admission is 6/8/2015. Date of service on consult is 6/12/2015. The pulmonary critical care team has been consulted for a chief complaint of hypercapnia, respiratory failure, ventilator-dependent respiratory failure, gallstone pancreatitis, cholelithiasis, hypovolemia, and urethral stricture, and Alzheimer's dementia. History of present illness. This 87-year-old male was admitted on 6/8/2015 with acute pancreatitis, found to be secondary to cholelithiasis on CT scan. The patient underwent a laparoscopic cholecystectomy with an intraoperative cholangiogram that showed a patent bile duct. The patient also had a urethral stricture, which was dilated in the OR under general anesthesia and Foley left in place. The patient was extubated in the OR recovery room, but subsequently became unresponsive and was found to have severe hypercapnic respiratory failure. His PCO2 was 134. He was reintubated in the recovery room and left on the ventilator overnight. He's currently being seen in the ICU and currently remains on the ventilator. ABGs this morning are much improved. His pH was 7.4, his PCO2 was 34, PO2 is 232 on 50%, and his bicarb was 21. FiO2 has been decreased to 35% this morning after those ABGs. The other event settings remain as AC14, tidal volume 515, a PEEP 5. We're currently doing a sedation, vacation, and weaning trial when the patient is awake enough. The patient is currently hypotensive with blood pressures ranging from 80/40s to 90/60s. He also has bradycardia in the 50s. The patient's CBC, CMP, and chest X-ray are insignificant. His past medical history includes Alzheimer's dementia, cervical disc disease, prostate cancer, and arthritis. His surgical history includes a laparoscopic cholecystectomy on this admission, a urethral neck dilation on this admission, a radical prostatectomy, and bilateral cataract removal. The patient is currently on Namenda and Aricept at home for his dementia. He is allergic to penicillin. He lives at home with current 24/7 care. His ex-wife actually manages his finances and assists in coordinating his care. He's fairly advanced in his dementia. He does not, nor has he ever smoked or drank alcohol. His family history, his parents are both deceased. His mother died of esophageal cancer and his father died of prostate cancer. His immunizations are up to date per his ex-wife. Review of systems is made difficult due to the patient's sedated and intubated state, so we obtained what we could from the patient's ex-wife at the bedside. She states he has no blurred vision or visual changes, no ringing in the ears or hearing loss, denies ear pain. She says he doesn't have any sinus issues or sore throat, no difficulty swallowing. She states that he denies any confusion or dizziness other than his baseline dementia, which is to the point where he knows her most of the time, knows their children most of the time, but sometimes does not. She says the patient didn't have any shortness of breath or dyspnea. He didn't have a cough. He had no chest pain or heaviness and no palpitations. She did say that he reported sudden severe abdominal pain. She wasn't exactly sure of the onset of symptoms, but it had gradually increased in intensity to the point where he was brought to the emergency room. She does report that he has difficulty urinating and says he denies any arthritis but has chronic neck pain. But on his past medical history in the computer, it does state that he has arthritis. She denies any history of eczema, dermatitis, or acne. On physical exam, his vital signs are as follows. He's afebrile. Blood pressure is 92/56. His pulse is 51. He is bradycardic. His respiratory rate is 14. He's not triggering the vent at this time. His O2 stat is 98% on the ventilator with FiO2 of 35%. General, the patient is a Caucasian male. He's lying supine in the hospital bed. He is sedated, restrained, and intubated at this time. His head appears normal with no noted malformations or trauma. His facial expressions are symmetrical. He does have perla 2 millimeters bilaterally. His eyes are free of redness or drainage. No exophthalmos noted. No discharge noted. He does have scleral edema. His ears, there's no apparent signs or symptoms of hearing difficulty, though it is hard to assess at this time. His ears appear normal and symmetrical bilaterally. His inner canals have no redness. His tympanic membranes are pearly gray with landmark and cone of light visualized bilaterally. He has no nasal redness or drainage. His neck is supple without swelling. No nodes are palpated. The throat is clear without redness or exudate. There's no JVD noted. He is orally intubated with a 7.5 ET tube taped at 23 cm lip line. Oral care is being done. The patient is 98% on the ventilator with the FiO2 of 35% at this time. There's no dyspnea, respirations are even and labored. Ventilator assisted. He's not triggering the vent. His lungs are clear bilaterally and diminished to the posterior basis. His blood pressure is hypotensive at 92/56. He does have sinus bradycardia at 51, as I mentioned earlier. S1 and S2 are present without gallops. There's no murmurs or rubs present. His cap refill is less than 2 seconds in bilateral extremities. His abdomen is flat. His bowel sounds are currently hypoactive in all 4 quadrants. There's no masses felt with palpation. He does have tenderness with palpation due to his recent surgery, and there are band-aids noted to the abdominal wall ×3 puncture sites. The patient has no kyphosis or scoliosis that I can see. He is strong. He does pull at restraints and appears to have good strength bilaterally. I was unable to obtain a good neuro exam because he's so sedated. His laboratory findings, the ones that I have at this time, are normal. His CBC, his CMP, and his renal function are all normal. His chest X-ray is within normal limits. Diagnosis and treatment plan. He has pancreatitis secondary to cholelithiasis. His cholelithiasis is diagnosis number 2. Number 3 is hypercapnic respiratory failure. Number 4 is ventilator-dependent respiratory failure. Number 5 is hypotension. Number 6 is Alzheimer's dementia. And number 7 is urethral stricture. Number 8 is oliguria. So we planned for the pancreatitis. We did status post-laparoscopic cholecystectomy with intraoperative cholangiogram. His LFTs have already returned back to normal. For cholelithiasis, he has already had his gallbladder removed, and the intraoperative cholangiogram was negative, showed no stones in the bile duct. He is in hypercapnic respiratory failure. He is currently undergoing sedation vacation and will obtain RSBI when the patient's more alert. We're not changing his current ventilator settings. We'll put him back to sleep and then do another sedation vacation in the morning after his blood pressure has stabilized, repeated chest X-ray and ABGs in the morning. His hypotension, we've given 2 LR boluses, 500 mils each, which have raised his pressure initially, and then his pressure has slowly declined. If he's unable to maintain his blood pressure and a good urine output of greater than 30 mils per hour, I will consider vasopressor support with Levophed. We'll get a procalcitonin to rule out sepsis and troponin and EKG to rule out any cardiogenic shock. The patient is oliguric. We're going to keep an eye on his eyes and nose to make sure he maintains a urine output of 30 mils per hour. He has Alzheimer's dementia. We're going to place an NG tube and start him back on his Namenda and Aricept home dosages. And urethral stricture, he's status post-dilation with a Foley placement. His urine is not bloody. It is clear and light amber at this time. Thank you.